So we will come to order, and thank you. We'll begin with bill introductions. Mr. Durst.
Thank you, Mr. Chairman and members of the committee. My name is Stephen Durst on behalf of Federico Durst Consulting Group. We are introducing a bill on behalf of our client, AARP Kansas, RS number 21 RS 1051, pertaining to savings accounts.
Thanks. Is there any questions for Mr. Durst? RS number was 1051, is that correct?
Correct.
Any further questions? Seeing none, is there any objection?
No, but I always like to remind lobbyists that they are not introducing bills. They are requesting we introduce them.
Or you may need to remind the chair. So thank you, Representative Miller. Correct as stated. Any other questions or objection to the bill? Representative Parker.
Thank you, Mr. Chair. I actually just had my own introduction. No objections or questions about the first bill.
Thank you. We will be to you shortly then, and thank you, Vice Chair. Other questions, or is there an objection? Without objection, the bill will be introduced by the committee. Thank you. The next introduction I would have is, I believe I see John Monroe. If you would like to do yours, if you would make the bill request.
Thank you, Mr. Chairman. Thanks. I'd like to request introduction of RS 1125. It's reimbursement of professional services by pharmacists.
So thank you, committee. Are there any questions? Is there any objection? Without objection, the committee will introduce the bill. Thank you.
Thank you.
Beyond that, let's see, Representative Parker, you had an introduction.
Thank you, Mr. Chairman. I have RS 1132, which is a bill regarding the lower limits of minimum insurance coverage for auto insurance.
Thank you, Representative. Are there any questions? Is there any objection to the bill introduction? Without objection, the bill will be introduced. Thank you, Representative. Representative Bishop.
Thank you, Mr. Chairman. Wow, should I mute myself? I'm using both. Okay, I'm now muted. Can you hear me via the mic, or should I turn the mic off?
Nope, the mic is good. Muting the computer was perfect.
Mr. Chairman, I would like to introduce a RS 0966, which is a cost cap on the cost of insulin for insulin-dependent persons who have insurance, and RS 0967, which relates to surprise billing and balance billing.
Thank you, Representative. Are there questions on either bill? Is there an objection to either bill introduction? Without objection, the bills will be introduced.
Thank you, Mr. Chairman.
Are there any bill introductions? So, I think we just need to keep our computers with sound off if we are in a room, particularly if we're in a room with a hot mic. So, and Representative Bishop, you may want to shut your microphone off as well.
I did turn it off, but the process of turning it off appears to set off something.
So thank you. It may still be working through one of the computers in that room somewhere. Perhaps our tech setup is carrying it through for us. So, are there any other introductions? Our last bite at the apple here. Make sure I take a look at the screen if anyone has their hand raised. Seeing none, I'm not sure. It's one of those mysteries. Do you have any sound on yours?
Mr. Chairman, is this better?
We'll try it again. Seems to be working at the moment. We're just having a lot of fun today. Anyway, thank you for the introductions. We will move on from that particular item, and we have the chance to have an approval of our minutes from January 13th and 20th. Those were distributed. Are there any questions or comments on those minutes? Representative Bishop, Representative Neighbor, I've done that twice. I know better.
I'm going to change my name, Elizabeth. Mr. Chairman, I would move acceptance of the minutes as written.
Motion by Representative Neighbor, seconded by Representative Riley. Any discussion? Without discussion, those in favor signify by saying aye. Aye. Opposed, nay. Ayes have it, and the minutes are approved. Thank you. Thank you, Representative Neighbor. Our next item would be a hearing on House Bill 2243, and I'd begin with an overview from the reviser.
Thank you, Mr. Chairman. Good afternoon. House Bill 2243 would adjust the frequency of the CAPERS actuarial experience study from once every 3 years to increase that to once every 4 years. The change in frequency would begin from the most recently completed actuarial study prior to July 1, 2021. And the bill also provides a delegation to the CAPERS Board of Trustees the power to adjust the frequency of such study from the 4 years specified in the bill to not more frequent than once every 3 years and not less frequent than once every 5 years, if the board deems it necessary in the fiduciary duty to act in the best interest of the CAPERS Trust Fund. Now, the bill becomes effective upon publication in the statute book, or also July 1, 2021. Some of you might remember a similar bill from last year, House Bill 2619, that made it through the House process and then got substituted in the Senate for some financial institutions provisions, and was ultimately vetoed by the governor. So this is really just a reintroduction and update of the bill from last year.
Thank you for the overview. Are there any questions, committee? Seeing none, I don't think there is a fiscal note that is meaningful. If there's any fiscal note within CAPERS, it could be a modest decrease by not having an actuarial review every 3 years and potentially longer. So we will move into our proponent testimony and welcome, as always, to the committee, Director Conroy.
Good afternoon, Mr. Chairman. Thank you. Glad to be here. I am here today to speak about 2243, and David's done a good job explaining the bill. It all relates to the CAPERS actuarial experience study. As indicated, right now the law says it has to be done every 3 years. This bill would give some flexibility to the Board of Trustees to do it every 4 years. So it'd be 1 year later. But should circumstances arise, the board would have the discretion to still go ahead and do the actuarial experience study every 3 years, or delay it up to 5 years, but not any longer than that. The current schedule is, that every 3 years. So the last one was, the board finalized it in January of 2020. Which covered the years 16, 17, and 18. The next scheduled experience study, it'd be for calendar years 19, 20, 19, 20, 21, or through 2022, excuse me. And so the board would start working on this then currently under the summer of 2022. If the bill would be approved, it would be delayed 1 year until 2023. And just briefly, actuarial experience studies look at all of the assumptions that the actuary uses in terms of doing that analysis. It looks at economic assumptions. It looks at demographic assumptions. And so those economic assumptions would include like inflation rate, investment return assumption, general wage growth, and all those, of course, are important when you're talking about 150,000 active employees and their salary base and how much is their salary going to change, the investment market, you know, and what's going to happen on the Capers Trust Fund with over $23 billion. Just that 0.25% change, let's say, up or down, can have a major impact ultimately on the status of the fund and the projected unfunded actuarial liability. On the demographic side, it looks at mortality and retirement rates, termination rates, benefit selections, because Capers members have some options there. And so all of those are reviewed. All those factors go in to calculate the liabilities, which then, I guess the point of it is, it sets the employer contribution rate. And so that's why this, I guess the bottom line, why the actuarial experience study is so important, because the board then, after receiving the actuarial experience study, makes their determination, and that rolls through to get to that required employer contribution rate, which all the 1,500 Capers employers, state, school districts, cities and counties have to pay. And so, and there's lots of different assumptions that can go into that, including, you know, the amortization method for that unfunded liability, asset valuation methodology, and there's lots of them. Two common ones are level percent of pay and level dollar, and then on down the list. And so lots of moving parts, but it's just how often would be an appropriate time to do the study. Our consulting actuary that we contract with says best practices 3 to 5 years are appropriate. Anything shorter than 3 years doesn't really give time for the demographic experience to kind of work its way through to see if there's been any changes since the prior one. Same one, if it's longer than 5 years, then you might miss some of those demographic changes or be delayed in realizing them. Our actuary has indicated, I think the most common one actually is 5 years, but she thought it would be appropriate every 4 years. She thought 3 years was kind of on the short end. 4 years would certainly be appropriate, or even 5. This still gives the flexibility to the board to make some changes. The bill would have minimal fiscal impact. It would just delay our payments for that actuarial study one year, and so, and of course the payments for that come out of the trust fund. So certainly glad to respond to any questions when appropriate.
Thank you, Director. Are there any questions? Representative Proctor.
Thank you, Mr. Chairman. So I got a couple questions. The first question, you said that this actuarial analysis affects the employer contribution. That the employer contribution was set as a percentage of what the member contributes. Is that not the case?
No, generally the members' contributions are set by statute. So for like Capers, it's at that 6%. And so all of this analysis in, you know, income into the trust fund comes from investment earnings, which is the largest, over half. Not quite a third is from employer contributions, and then the balance is from employee contributions. So in defined benefit plans, the plug factor is, of course, investment earnings go up and down. Employees are fixed, and it's the employer contribution then that has to be adjusted to get you to that actuarially required rate based on the amortization period, in this case, 2033. So that employer contribution rate fluctuates based on this analysis to meet the actuarially required rate based on all those assumptions, if that helps.
That does help, thank you. And then the other question, this is probably obvious to everybody in the room except for me, but were this bill to pass, This would in no way impact by making it easier or harder if somebody later wanted to re-amortize capers?
I think that's true. I mean, currently, it's a delegated authority to the board. So either currently or if down the road some point, the policymakers wanted to change that, again, that delegated authority could come back from the board to the legislature as set by a future piece of legislation.
I'm probably not asking the question right, but this bill, which would extend the period between this actuarial analysis, doesn't in any way affect reamortization?
It does not in on its face, that's correct.
Okay, all right, thank you.
Further questions, committee? So I'd have just a couple, Alan. As we looked at the things that we might use the actuary for, is there a study aside from the experience study that deals with valuation on a schedule that is separate, or is it all tied into the assumptions?
There is an annual actuarial valuation study. So an experience study is done every year based on all the information that comes in. And then this triennial experience study is a review of those prior 3 years to look at the experience for all those assumptions that are set by that actuarial evaluation. Are they reasonable or appropriate?
So thank you. So each year there's a study just to set that valuation using these assumptions. And currently every 3 years we do a check of our assumptions to say, are we using good figures to come up with our annual valuation?
That is correct.
Would this also give the board authority to do different things? For example, they may say, well, we want to do our economic assumptions pretty regularly in case they're changing, but we feel like our demographic detail is not changing as much, and we might move that out to 5 years and hold economic at 3 years, for example, or is it all wrapped in one?
I believe it's all wrapped together. The triennial experience study, the first 6 months analysis looks at those, the economic assumptions. There's an asset liability study that's done that looks mainly on the investment side. And then the last 6 months gets into the broader economic assumptions within those demographic ones. So it's about a year-long process, but for the triennial experience study, I believe they're tied together.
So thank you. And my final question is, what would the board look at to try and make that decision on whether to extend? And is it likely that they'd say, well, we'll extend 1 more year, review the following year, and say, well, we think we'll go to the 5th year? Or would they set a policy, and what might they try and use as a metric to set that?
Probably starting out, they would probably consult with the actuary, particularly seeing if she's seen anything in those annual valuations that maybe, let's say on the demographic side, that might cause some concern or might warrant additional detailed study. So I think it'd be in consultation with the actuary and our general investment consultant.
Thank you. Any other questions? Representative Berquist.
Thank you, Mr. Chair. Just a question for you. If the board was to make a move or needed to recommend reamortization, would it, if within the board, would it be only for the health of the fund itself and not for any other cause?
I believe so, or at least beyond, I guess, sound actuarial principles. We've heard from our actuary, again, our current amortization period is 40 years. We're down, going to be getting in that 12 to 10-year range here before too long. And so the actuary has said when you get certainly within 10 years, it's appropriate under actuarial methodology to look at reamortization. Again, it causes, as the window gets narrower, the volatility in those employer contributions goes up and down because, again, they're the plug factor, and the goal is to have it paid off by the end of the amortization period of 2033. So, yes, I guess is to answer your question.
Thank you very much. Thank you, Mr. Chair.
Representative Miller.
Thank you, Mr. Chairman. And the chair alluded earlier about the fiscal note. It is he said meaningful. I would use the word confusing. Just to be clear, are we going to save any money by doing this? Or because it says we have a built-in contract, or is the contract, are we committed regardless of whether it's 3, 4, or 5?
No, if it's, let's say it is extended out 1 year, then we would not pay the actuary to do that in the year that it's under the current contract, and we would revise that, so it'd be delayed a year. We'd still spend it, but not in the year that.
But we're not going to pay $55,000 every year, even when they're not. Thank you. Thank you, Mr. Chairman.
Thank you. Further questions, committee? So, and I think in the fiscal note, just to continue with Representative Miller, we had, was it 55,000 for that? So in effect, we'd either be spending 55,000 over 3 years or potentially 55,000 over 4 years. So it might be slightly less, but we wouldn't be saving 55,000, but somewhat the frequency with which we'd be spending it. So thank you for those questions. Anything further, committee? Seeing no further questions, thank you, Director Conroy. I have no other conferees that are listed, but is anyone wishing to appear as a proponent of 2243? Anyone is an opponent of 2243? Anyone neutral? And anyone at all on 2243? Seeing none, we will close the hearing. So thank you for bringing that before the committee. We have a couple of other topics that we will get to. One, if we have time, the Vice Chair has prepared some information just as a flow chart of how the process works. So perhaps we'll get to that either at the end of today or on Wednesday. So thanks for putting that together. But our next topic is an informational hearing on mental health parity. And so we'll start that informational, and Representative Neighbor, would you like 2 seconds to set it up, or should we turn it to our first conferee?
Thank you, Mr. Chairman. We had a parity bill that came to us in insurance last year, but like many other bills, they got lost in the COVID. And it's also a very deep bill. And my concern was we have a lot of new members on this committee, and in order to ask good questions or to understand what the parity bill does or means, I thought it would be good just to have an informational meeting. This is not in regards to the bill itself, but it is to explain what parity is, where it is nationwide, and so I would turn it over to Amy Campbell.
There it is. Okay. Seems like every hearing sort of starts out that way this session, doesn't it? My name is Amy Campbell, and I work for a group called the Kansas Mental Health Coalition. The coalition is a roundtable organization. The community mental health centers are members, some private hospitals are members, the Psychiatric Society, social workers, along with some consumer organizations like Mental Health America and NAMI, Keys for Networking, Breakthrough Clubhouses, and many more. Our existence is simply to bring everyone together once a month and develop a consensus agenda. And we only lobby for those things that everyone at the table agrees to. My background with mental health parity is that I was first hired by the Mental Health Coalition when it was a tiny organization to pass the first mental health parity statute in Kansas. For too long, Americans have paid for insurance coverage that did not recognize that mental health and substance use disorders are every bit as important as physical health, and that going without that treatment can be debilitating and even life-threatening. I have attached at the end of the testimony a full timeline of federal action as the federal government has passed various statutes and passed various rules and regulations in order to enact mental health parity. The first federal Mental Health Parity Act was enacted in 1996. In 2008, the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act was signed into law. And then in 2010, the Affordable Care Act enacted and extended parity protection to individual health insurance policies and Medicaid expansions to low-income childless adults. The Kansas Mental Health Parity Act was initially passed in 2001, and then in collaboration with the Kansas Insurance Department and the insurance industry here in Kansas, it has been updated in 2009 and 2018. I've included some primary points about our Kansas Act here. It says that any group health insurance policy shall include coverage for diagnosis and treatment of mental illnesses and alcoholism, drug abuse, or other substance use disorders. Such coverage is subject to the same deductibles, co-payments, co-insurance, out-of-pocket expenses, treatment limitations, and other limitations as apply to other covered services. And it shall include treatment for inpatient care and outpatient care. It is important to note that our state statute does not apply to small employer group policies as defined under the statute. If you do go back and look at the long list, the timeline looks like this. You can see how many times the federal government has acted to apply mental health parity to different types of large group policies, including ERISA plans and others. So the federal CMS guidance regarding these parity requirements includes CHIP, Medicaid, and group insurance. Suffice to say, the major point is that financial requirements and treatment limitations are to be no more restrictive than those applied to medical surgical benefits. That right there is the nut of what mental health parity means. No separate qualifying criteria may be applied. When out-of-network coverage is available for medical service surgical benefits, it must also be available for mental health or SUD benefits. So that's your basic outline of what mental health parity is according to federal and state law. So if mental health parity is the law, why do we keep hearing about it? One of the most important promises of both the ACA and the Mental Health Parity Act was to provide benefits that are comparable to their coverage for general medical and surgical care. But parity is only meaningful if health plans are implementing it well, consumers and providers understand how it works, and there is appropriate oversight. This is according to the Parity Implementation Guideline set out by the Department of Health and Human Services. So this is where things get technical, and this is what Representative Neighbor was talking about. When people talk to you about what insurance does or doesn't cover, there are details involved that get really deep for all of us very quickly. For one thing, you have quantitative limitations, such as no more expensive copays, not requiring higher out-of-pocket expenses for behavioral health. Those are quantitative limitations. There are also something called non-quantitative limitations. Such limits like that have been keeping patients from realizing the true intent of the federal parity law. Those limits include things like differences in how health plans enact utilization management or define medical necessity, separate deductibles or copays for mental and medical health care. In other words, it's not included in your spend down at the beginning of the year. Limited behavioral health care services offered within the provider network, limited behavioral health provider networks, and lower reimbursement or additional audits and scrutiny for behavioral health care providers. The impact of these kinds of limits can be significant. Behavioral health patients are 4 times more likely to go out of network to get care, which raises the cost for those services. The Milliman report found that out-of-network providers provided 32% of behavioral outpatient care in 2015 compared to 6% of medical surgical care in the same setting. Do consumers and providers understand how it works? Well, policyholders, like you and me, are rarely skilled at reading the fine print, navigating appeals processes or deadlines, or knowing where to turn for help. That's why you often find them coming to you to solve these problems for them. The condition can be much worse when you are facing your own behavioral health crisis or that of your children. Providers must engage billing staff and dedicate extensive time to navigating the claims processes, and often there are behavioral health entities contracted by the health plan to administer the prior authorizations, utilization review, and payment processes for that plan. Last year, you all did hear testimony on a bill, and it was difficult. There were grieving families and frustrated providers who talked about the barriers that Kansans encounter with insurance coverage. I've bulleted a few of the most commonly cited issues that we hear about, and these are issues that you may hear about. The patient finally agrees to go to treatment only to find that there are no beds, or there are no providers, or their health plan will not pay for the treatments that are available. Providers may fight repeatedly to prove whether or not a patient is at risk of suicide or relapse, regardless of the screening that was conducted. Patients in crisis may be rejected due to a lack of prior attempts at lower levels of care. And in the most tragic cases, as you all have heard before, these individuals may take desperate measures that threaten their own lives or even result in death in an attempt to receive treatment. Poor reimbursement rates and excessive administrative burdens lead behavioral health providers to refuse participation in insurance plan networks. Out-of-network services require more expense for the patient. So these are some of the problems that you can encounter. By no means do we say that all health insurance plans have these problems. On the other hand, you have examples of health insurance plans across the country that have worked with the federal government, with our own insurance department, to implement modernization of healthcare services. For instance, one of the best examples, and I didn't put it in here, but I really should have, has been the use of telehealth throughout the pandemic to make sure that people are receiving services that they need, even though they could not receive them in person. So that sort of lays out the symptoms that you see and the conditions that are most often tied to mental health parity. I'm going to hand this over to Steve Kearney from the Kansas Psychiatric Society to speak about the oversight and the regulation aspect.
Cameron, am I far enough away from everybody? I can peel this thing off. You can actually hear me? Yeah? Okay, thank you. Well, good afternoon, everybody. I am Steve Kearney. I'm here appearing in my capacity representing the Kansas Psychiatric Society. That's a district branch of the American Psychiatric Society, so like the state branch of the APA. They're the folks that, for example, put together the DSM-5, it is now, but they're the folks who put together the diagnostic and statistical manual that pretty much all behavioral health and substance use folks employ in their diagnosing of mental illness. So I'm going to pick up a little bit where Amy left off, and you're going to watch me juggle pages up here a little bit, I'm afraid. So one of the things she left off with is the idea, is there appropriate oversight of coverage and for the mental health classifications. And one of the things that's happening now, and has been happening I think for a little bit, is that the NAIC, the National Association of Insurance Commissioners. Yes, sir.
Sure, the other room is having a hard time hearing you, so
oh, it's okay.
make sure you're speaking.
A little closer. All right. No, no worries. So what's taking place, or has been for a little bit, is that the NAIC, National Association of Insurance Commissioners, has put together a working group to assist states as they're trying to navigate some of the jurisdictional problems that take place, and you'll hear this a lot. I don't know if Brad or Larry Ann or Sonny or someone's going to speak from one of the health plans, but what it amounts to is this, that in large part at the state level, the insurance commissioner really doesn't have any teeth to regulate ERISA plans that are established under the federal guidelines. So that is what's precipitated this NAIC working group to begin to help states be a little more uniform, maybe get those things to interact together a little better. Some sort of a template for providers, payers, and everybody else, I guess, across the nation. So when Amy talked to me about doing this part of it, or the biggest part of it, was going to be talking to you a little bit about the WIT versus United behavioral health decision. And she has that in her materials that she prepared here. So, and I've got a couple pieces to talk to you about with it. This lawsuit was for a period from 2011 to 2017, and there's over 60,000 claimants that were involved in this that had their claims for coverage for behavioral health or substance use denied. And you might just write down at the top of your paper, here's the buzz phrase everybody's eager in: medical necessity. If you get some behavioral health treatment and you receive a letter, oftentimes it's from a contractor that some of the companies will hire a third party to process their behavioral health claims from their participants, and they'll look those over and determine whether or not they fit inside their criteria for medical necessity. So you ever see one of those letters, right? It says not medically necessary, or we find that it is medically necessary or was medically necessary for this treatment. What happened in UBH, WIT versus UBH, was this: that they had their own internal guidelines where they had their own algorithm, their own set of structure for what exactly is medical necessity for them, not accepted guidelines for everybody else or for the rest of the behavioral health community across the country or any of that. They worked out their own guidelines, and they were driven largely by money. Imagine that for any of us, right? Find a couple little bits here. So they were making these coverage determinations based on criterion that they had developed that were much more restrictive than the generally accepted criteria for that type of treatment. And they were prioritizing cost savings over the treatment. So what they found, and I think you all are probably familiar enough with our system here in Kansas now, in terms of mental behavioral substance use treatment. If somebody is in a really acute episode, about the best you can get, and it's not throwing any stones at the state of Kansas, but about the best you can get here is a 3-day stabilization ride. Get you down so you're not necessarily a danger to yourself or others, and get some treatment, medication adjustments and the like, and then you're back out. And that's not a function necessarily of what the insurance companies are doing. That's a function of just the availability of treatment for behavioral health in Kansas. We just have a dearth of psychiatrists, of everybody that can provide the treatment. So you can imagine in that kind of a scheme, if you think about, well, what usually happens is somebody has some sort of a break, and they're taken to the ER by their family, their friends, sometimes by the police or others. They take them to the ER, they get evaluated, they get some medication adjustments, they get put in kind of an intermediate care bed somewhere, and then off they go once the acute episode is over. So what's taken place, and took place in this case, is this: that when you have an emphasis on only the acute, So if somebody is persistently mentally ill, yeah, it's something they're going to struggle with all their lives. They're bipolar, they're schizophrenic, and things that are going to cause them difficulty throughout the course of their lives. Those are chronic conditions, not acute. There may be some acute aspects, but they're chronic. They go on and on. So many of those claims were getting denied with emphasis only on acute, because if you can roll somebody in and out in 3 days, and they're calling it good, right? So claims were being denied in this case based on whether or not they were chronic through the guidelines that these folks had. So I know of one member of the KPS who has a smaller practice, but the patients he sees are very complex, difficult patients with some of those very, very chronic conditions. So for him, here's the, this is kind of the idea that, so if you have sort of an algorithm or other way as a company that you're determining this, and you look at, so Steve Kearney's, God forbid I'd have any patients around, but Steve Kearney has patients, but they aren't, this is one of the keys, are they like steadily improving towards, ceasing, or are they going to be well, right? Like appendicitis, they're going to take out my appendix, I'm going to be okay after a bit, get sent home. So they don't seem to be improving, and the disconnect with that kind of chronic mental illness is this, that the fact that they are not descending in their behavior, that they're functional, et cetera, that's a win. But in this particular instance, that's not how they were going after it. So medical necessity, acute versus chronic. And the court found that they were using flawed medical necessity criteria in UBH. Representative Miller will like this, I suspect, that so the court made their decision.
Mr. Carney,
yes, sir.
Your time is now a little over 10 minutes. So
okay.
15, so if you have a couple key points for us, and I want
Sure.
to make sure
I'll
we
just,
have some
I'll
time
tell you
for
that.
Michelle.
Sure. Landmark-wise, with this case, this court really set out some very, very specific guidelines, and in November of 20, they established remedies in a separate order. And for Mr. Miller, he knows they ordered a federal master to govern all of the compliance for UBH for 10 years. That's never something you want to hear if your client's the one getting the federal master visit on, right? They're going to be reprocessing close to 70,000 claims from that period of time. So there's a lot of very pertinent findings in this that you can look at and see, is that what we're having happen here or elsewhere? And I'll stop. Thanks, Chairman.
Thank you, and thank you for that summary.
Mr. Chairman, on the last pages here, you'll see that we talk about what other states have done as a result of what they're finding across the country. Legislation has passed in 4 states. And then the final page is just to talk about what you might see coming to you that might come under the application that people describe as dealing with mental health parity. States look at mandates for coverage of specific conditions and payment for specific treatments. But looking at actual parity is designed to actually get equality in policies. And you can do that through cost containment tools, empowering state regulation, and asking your health plans to use accepted standards of care and medical necessity criteria. We have Michelle Ponce on, who can talk to you on the public mental health side of this. But to suffice to say, we really just wanted to be here to say there's a volume of information. And the issue is important, never simple, but we are always happy to sit down and talk about what the best solutions are. Thank you, Mr. Chairman.
Thank you, and we have a few minutes to hear from Ms. Ponce. If you
yes, good afternoon. Thank you. Mr. Chairman and members of the committee, my name is Michelle Ponce, and I'm the Associate Director of the Association of Community Mental Health Centers of Kansas. Our association represents all 26 licensed community mental health centers that provide services in all 105 counties of the state. As part of licensing regulations, our community mental health centers are required to provide services to all Kansans needing them, regardless of ability to pay. And this makes the community mental health system the safety net for Kansans with mental health needs. Thank you for the opportunity to be here today to talk a little bit about mental health parity. I think Amy and Steve did a really nice job providing an overview of parity and why this is such an important issue for the patients we serve. So I'll keep my remarks brief. Community mental health centers really strive to provide quality care, treatment, and rehabilitation to individuals with behavioral health problems in the least restrictive environment. They support treatment at the community level in order to allow individuals to continue functioning in their own homes and communities at a considerably reduced cost to them, third-party payers, and taxpayers. They provide treatment and recovery services to Kansans covered by Medicare, Medicaid, private insurance, as well as those who are uninsured or underinsured. Amy mentioned the first federal parity legislation was introduced in the early 90s. Though no action was taken at that time, multiple measures were taken between then and the passage of the Federal Mental Health Parity and Addiction Equity Act in 2008 that aimed to create parity by eliminating differences in group health insurance coverage for mental health and substance abuse benefits as compared to medical surgical benefits. More recently, in a landmark ruling, a United States District Judge ruled in WIT, the United Behavioral Health, that the country's largest managed behavioral health care organization illegally denied mental health and substance use coverage based on flawed medical necessity criteria. That's the issue that Steve was just talking about. The decision in WIT establishes a precedent for plans covered by the federal parity law requiring that they pay for continued treatment for mental and substance use disorders, just as they would for any other chronic illness. We agree with that decision and believe that treatment decisions should be made by qualified mental health providers with their patients and their families, who are in the best position to determine patients' needs. Some key takeaways from the WIT decision include that effective treatment requires treatment of co-occurring mental health and substance use disorders and/or medical conditions in a coordinated manner that considers the interactions of each of those disorders. It also states that patients should receive treatment in the least intensive and restrictive level of care that is both safe and effective. Effective treatment includes services needed to maintain functioning or prevent further deterioration. The appropriate duration of treatment for mental health and substance use disorders is based on the individual needs of that particular patient. In addition, we have two further important points to bring to your attention. First is regarding timely access. Timely access to care is vital. Delayed care may cause an individual experiencing a mental health need to become more ill, need more services, and take longer to recover. Individuals may delay seeking care due to concerns of cost and/or insufficient coverage, or care can also be delayed as patients and providers spend time attempting to override treatment denials if a payer does not use accepted practice standards for utilization review. Second, transparency and information are important both for patients and providers. To that end, we believe that all health insurance companies should be required to submit a core set of information to the Kansas Insurance Department regarding processes for determining medical necessity criteria, identification and analysis of non-quantitative treatment limitations, and procedures to ensure compliance by health insurance companies. I would like to add that our community mental health centers around the state have good relationships with several of our large insurance companies. Ultimately, our overarching goal is to connect patients with the right treatment at the right time in the right place and to reduce the number of unintended consequences to the greatest extent possible. Thank you again for the opportunity to appear before you today, and I will stand for questions at the appropriate time.
Thank you for your testimony. Our next person providing information is Sunny Mickle with Blue Cross and Blue Shield. And if you are ready to join us, we'll turn it over to you.
Yes, hello, Mr. Chairman. Can you hear me okay?
I can hear you, and you could have as much as 20 minutes, but what you need will be great.
I'm sure I won't take that long, but thank you for having me here today and members of the committee. This is such an important issue for Blue Cross and Blue Shield of Kansas. Again, my name is Sunny Mickle, and I'm the Vice President of Government and Community Relations at Blue Cross and Blue Shield of Kansas. We're the locally operated mutual insurance company right here in Topeka, and we have over 1,600 employees that work in 12 cities around the state. But we also serve 930,000 Kansans, so it's very important for us to make sure that we're not only treating and covering their physical health, but also their mental health care needs. And I really appreciate the testimony from Michelle, Amy, and Steve today. They really touched on a lot of the things that we have been tracking and working with over the years as well. Mental health parity is something that is not new to us, but it's really a confusing topic because of the way it interacts with commercial health insurance plans and other plans that are operating around the country. As you heard from Amy and others, there are many plans that do not have to follow mental health parity laws. Even though back in 2008, the federal government did pass the Mental Health Parity and Equity Act, it's also troubling because we want to make sure that our members know what they're purchasing. And when they're out there and they're shopping for plans, it's not very clear. Insurance is a complicated process. And even when you have an insurance plan that does follow the mental health parity laws that were set by the federal government and our own state government, you will find that there are other plans that are just not as rich of a benefit for both medical services as well as mental health services. So let me just take a quick step back, though, if you don't mind, to really talk about what commercial health insurance plans have to cover and what they have to comply with under the Federal Mental Health Parity, Equity, and Addiction Act. So you have a lot of plans out there, like I said before, that are fully insured and self-insured plans. And those plans must follow the Federal Mental Health Parity, Equity, and Addiction Act. Those include those employer group plans, their individual ACA compliant health plans that are sold here in Kansas today, both on and off the exchange. Those individual policies, those non-grandfathered plans, have to follow the federal mental health parity law. That's different than the older plans that were sold back before 2010, those grandfather plans. They're a little bit different, but for the most part, most Kansans today have individual ACA compliant health plans, and those plans have to follow the federal mental health parity law. That's examined by the federal government, CMS, when insurance carriers like Blue Cross actually submit our plans for review. Also, that's examined by the Kansas Insurance Department. There was a great comment that was made about having the Kansas Insurance Commissioner take a closer look at all the policies that are filed to make sure that they are explaining exactly how they're implementing their mental health benefits, to match those up and show that they are in parity with those medical benefits that are also covered, and also to touch on the non-quantitative treatment limits that are being applied. I know that NAIC, the National Association of Insurance Commissioners, is talking about model legislation and how to do that across all the different states. But in Kansas, we're ahead of the game already, and a lot of people may not be aware of that. The Kansas Insurance Department began requiring plans that are filing for coverage on the exchange, as well as other policies that are being sold and under the regulatory oversight of the Insurance Department. They required, as of last year, for all those plans to submit and map out their mental health benefits to prove that they are in compliance with the Federal Mental Health Parity Act, as well as state mental health parity laws. That is a huge undertaking for those insurance companies that are regulated in the state, but it does help demonstrate to the department that we are following through on what we have said. And then if there was a plan, perhaps, that had an issuer question and a member had an inquiry, the insured had an inquiry and sent that inquiry into the insurance department, it gives that insurance examiner the opportunity to match up the benefit plans we've already filed with the information we filed on mental health parity, and they can determine whether or not we followed through as we said. It's also important to understand that there are other plans that have to follow the federal mental health parity laws, even if they're not under state oversight. And I know this was touched on as well. So the CanCare plans, those MCO plans, they have to follow federal mental health parity laws. The state employees' health plan also has to follow the federal mental health parity laws, and they also submit themselves to be underneath the laws of the state of Kansas. So they are also following the state established mental health parity laws that are out there today. So what that means basically is that all of these plans are then complying with and showing that they're having equal treatment for deductibles, co-insurance, and co-pays for both medical surgical benefits as well as mental health benefits. What we sometimes find, though, is that we have people that want to have benefits that are more favorable for mental health services. But under the way the law is written today, if a plan is implemented in such a way that favors mental health benefits, that also is an outlier and does not comply with the law correctly. And I can tell you at Blue Cross of Kansas, we've actually had some plans where that has been the case. We've submitted them to the federal government, to CMS, the Centers for Medicare and Medicare, and what they identified is that the plans did not meet the criteria to be sold on the exchange because they were not in parity with each other for both medical and mental health services. States are allowed, though, to pass more extensive mental health parity laws, and that's what we've done in Kansas. And Amy walked you through that very well, that Kansas wanted to outline exactly what was important to them from a mental health parity perspective. But it's also important to keep in mind that they have commercial health insurance plans that are following those state laws if they're fully insured. But if they're a self-funded employer plan, these are plans that the employer takes on that insurance risk themselves. Also, there are many association health plans that are self-funded. Well, all of those types of self-funded plans are not under the purview of the Kansas Insurance Department. So any state law that's passed for mental health parity does not apply to those self-funded plans. The majority of the commercial market in Kansas is actually under self-funded insurance programs today. So you see a lot of people that will not be touched by any laws that are passed specifically in Kansas. And that's why it's so important to have things happen at the federal level so it overlays those self-funded plans as well. Also in Kansas, we have a lot of plans that are called short-term limited duration insurance policies. And these are mandate-late policies. And these laws that are on the books today in our state allow them to cover mental health treatments, I should say, not mental health parity, but mental health treatments. But some short-term policies don't offer that today. At Blue Cross of Kansas, we're not selling any short-term policies, but I can tell you that amongst those that are sold, people are attracted to them because they're lower cost products. They then carve out a lot of these benefits that people find to be beneficial, but also can be very expensive. And then they're limited from both a medical and a mental health standpoint. And if someone is on one of those policies today, any laws that are passed in Kansas will not fall onto those, and you will still have people that are out there with substandard coverage when it comes to the mental health benefit perspective. Another thing to remember is that there are a lot of non-regulated insurance policies that are being sold in Kansas today. And by non-regulated, I mean they're not falling underneath the federal government or the state government. These are policies that consider themselves to be non-insurance, and as such, they don't have to comply with the Federal Mental Health Policy, Mental Health Parity Act either. They also don't have to apply and have all the same medical benefits either. So you have people that are purchasing these things and calling them health insurance or health plans, but they really don't have the types of benefits that people need when they're in crisis, for whether it's a medical crisis or a mental health crisis. One other thing I wanted to point out today is about how there are plans out there that are complying with mental health parity, but because of their deductible structure, they're not affordable for people when they are in a time of crisis. So for example, it's very popular to have high deductible health plans. High deductible health plans are common not only in Kansas, but around the country. They're the structure that's been defined actually by CMS when you're selling individual coverage on the health insurance exchange, and it allows, again, for a more affordable product. However, you have individuals then that have deductibles that are at $6,000, $8,000, $9,000 in some cases. So if they're needing inpatient care for a medical service or a mental health service, they're going to have to meet that deductible at some point. And that puts that patient obviously in a predicament where it's hard for them to pay for those services. And they may be going without services in some situations on both the medical and mental health side. Plans that are also being sold in Kansas today are falling under what we call an EPO network, an exclusive provider organization network. They're the most popular plans sold on the health insurance exchange, and they're also very popular in the small group market. So back in 2016, the Kansas Legislature actually passed a law that allows for these EPO plans. They are very similar to HMO plans, but when people purchase them, they don't realize that. We, as insurance companies, do our best to educate members about this, but I can tell you when people are shopping on the insurance exchange, they typically are sorting, like you would sort for anything as a shopper, and they're looking for the lowest cost plan. Not recognizing the lowest cost plan may leave them then with coverage that makes it difficult for them to seek care with providers that are outside of that network. So EPO plans, like HMO plans, typically do not offer out-of-network coverage for non-emergency services. So unless someone is going into an emergency room, an acute care center for an emergency service, that person then is going to find that they don't have insurance coverage for seeing a mental health provider, let's say, that's out of network, or a medical provider that's out of network. And that's typically a problem we hear about. So when you see people saying that they want to go to a provider and they're being turned away and they thought they had insurance coverage, that's usually what is happening. And it's very difficult to explain that to people, especially when they're sick and have a physical ailment or a mental health condition. A few other things I wanted to talk about are the fact that this is not a new concept or issue of importance for Blue Cross of Kansas. So Blue Cross of Kansas has always looked at physical and mental health as being very important, and we've built tools that our members can use, our folks that are insured with us can use. And they're within our Healthy Options program, so people can actually go out there and request assistance even if they are concerned about a complex medical condition. We also have a program called Strive that's powered by WebMD1, and that includes tools for physical and mental health needs. And then you probably have seen a billboard in town or maybe even seen a commercial on what is our new campaign